on to our next speaker, Dr. Nichlani, who is a phaco-refractive surgeon from SV Eye Care Center, Bhopal, Madhya Pradesh, a very well-known figure in ophthalmology in our country. And he is going to show us a challenging case. On to you, doctor.
Thank you, madam. Thank you for giving me a chance to share my thoughts. I'm going to share my screen and let us see. Yes, it has come. Let us make it full screen. So here is a case of uveitic, post-uveitic cataract. See the screen? So you can see the posterior synecdoche all around the main.
Can you mute yourself, please?
I'm just going to remove the cyclitic membrane, and many more times you get a little bit of hyphema or a little bit of bleeding itself. But taking out a cyclitic membrane is the mainstay so that the pupillary margin remains free and you can have a better dilatation. Once that part is done, it is always mandatory to stain the anterior nucleus. Whatever anterior capsule is there is available, you can stain it, but many more times you may not get enough dilatation. Then you can definitely stretch the pupil to a limit from where you can do the phaco itself. These cases, many more times you get a fibrotic capsule, so you initially find a little difficulty in puncturing the anterior capsule, but with the help of two sharp instruments, you can definitely puncture the anterior capsule. And to cut the fibrotic anterior capsule, you can use vitreous scissors that will definitely give you a circular capsular axis. While doing hydrodissection, I got a kind of sense that probably the posterior capsule is not intact. So I start delivering the nucleus, which is semi-calcified kind of thing, pushing up a viscoelastic agent into the bag and then trying to deliver the semi-calcified nucleus or the cortical material into the anterior chamber, but it was coming in a piecemeal. So I thought, let us take help of two instruments together. That will definitely help to take out the cortical material, the calcified cortical material or the nucleus itself. And this is how it was brought into the anterior chamber. Practically whole of the calcified material. Uveitic cataract, they do have this kind of calcified cortical material with the nucleus itself. I could not find out a good red reflex, so I thought I would say rather going into the simple irrigation aspiration of phacoing the cortical material, IOL scaffold would be a better chance to keep the vitreous away from coming into the anterior chamber, and this soft cortical material was taken out with the irrigation aspiration, but it can be taken out with phaco itself. Once that irrigation aspiration is inside, you always attempt to practically take it out with the piecemeal or a kind of eye aspiration. So once it is taken out, I tried to see if any of the cortical material left in the bag, but since there was not much of the red glow from periphery, red glow was seen, and I was again skeptical that there could be a chance of posterior capsular rent in the periphery. So I decided to implant IOL in the sulcus itself. You can see the thick capsular axis or the capsular margin of the anterior capsule that is giving a good support to three-piece IOL. And this is how I put the IOL in the sulcus, later on stained with the orocort and tried to see if any strand of the vitreous, but fortunately there was no vitreous itself, and this is how it was all completed.
Thank you very much. Thank you very much, Dr. Nichlani. That was a challenging case which you showed. Of course, I would have preferred to have removed it with phaco if I have anyway put a IOL scaffold. Shrish, I'm going to ask you one question. What would be the inflammatory control which you would work out for these patients in the pre-operative before we pick them up for surgery? And the
eye has to be quiet for some time, at least for 1 month, they say, we are consultants. So it has to be quiet. And using iris stretching instruments is actually only, it is indicated in these kind of cases, this complicated cataracts. As such, there is no role for stretching nowadays in other cases. It is the only indication for iris stretching. So control the inflammation preoperatively and postoperatively. I put them on prednisolone acetate instead of loteprednol and slowly taper them, and till the eye is quiet, I continue steroids. At least for 3 months, it can go on. And the chances of, again, the formation of synechia is there. If the IOL is in the bag, you can put them on cycloplegics. If it is not in the bag, there is every chance of posterior synechia formation, and it can even lead to secondary angle closure glaucoma at a later date. In such cases, it is a good idea to do a PI in these cases.
I think I would have
a retina surgeon and
couple of weeks.
we get yes.
Yeah, no, I would have put them on steroid drops pre-operatively for a couple of weeks. And I also believe that I would have tried to place the IOL in the bag. Did you have a PCR? Why you didn't place it in the bag?
Madam,
because you felt the visibility was less.
Yes, it was not visible, and probably.
Don't you think then I want the experts to advise? Won't you think that so much of anterior lens cap plaque which was left behind, that itself could have become a indolent inflammation over the period of time?
It was not a plaque, madam. It was basically a fibrous anterior capsule. All cortical material which was fibrous or which was calcified was taken out. I could see, say whatever the window available from the anterior capsule, there was no cortical material, but initially it gave me a kind of sense that there could be a PC rent. So I thought not to put IOL in the bag and not to try it. So that was the only reason.
I don't know, it felt as if that the capsule, it was not just the capsule which was opaque. I did feel that it was a plaque, or at least plaque all around. Then you need to address that. There are different ways you do it. If it's a fibrous plaque, you have to actually cut the rhexis and get make it a larger rhexis so that you remove the plaque along with it. And if it is a subcapsular plaque, you need to go under plane and inject hydro so that you loosen up it from the capsule and then remove it. I don't know. This is how I thought.
Use of iris hooks in these cases, I think, would have increased the visibility, and probably that's the first step, so that all the other steps would have become much more easier, and I think clarity of decision making would have been much better. Probably excellent surgery, sir.
Excellent surgery, but
yeah.
In such cases, in such cases, I'll tell you the first thing you asked about the pre-operative thing. So depending on the cause, most of the time we are dealing with the particularities with the complicated cataract, like this kind of cases.
Yes.
So it is preferable to do such cases all under the steroid cover, oral cover of the steroid.
Yes.
So we start at least 4 days prior to the surgery, oral steroid, and anti-inflammatory at least a month before.
Yes.
And the uveitis or any activity should be not there, documented at least 6 months before the surgery.
Yes.
So that is the ideal scenario. And as I said, the documented 6 months, that means there should not be any history of pain, redness, any cells or active flare into the eye. and it always has to be done under the steroid cover. You can give a short cover of the steroids for 1 week after surgery. Second, at the time of surgery, generally these cataracts are the soft cataracts. They are not the hard cataracts. It's just NICLANI which are there. So when you start the surgery, as Dr. Harur was asking, the iris hooks, try to avoid, because this leads the least manipulation or touching of the iris. So as we say, the cataract is generally very soft. So once you enter with the viscoelastic, it dilates a little bit, then release NICLANI with your cannula gently, and most of the time find there is a slight membrane under the pupil. So if you give a small pupilloplasty, you just cut the pupil margin, it dilates enough for the surgery. So you don't need to dilate or anything. The main thing is that during the surgery, do not touch the iris at all. Stay into the center, and with the chopper, try to feed this lens metal softly into your hands. And just with the vacuum, not using much of the fake cover, you can just complete the surgery. So the most important part into this is also to achieve good rhexis. So when you're doing the rhexis, always stain your capsule and try to achieve your rhexis slightly larger than what your pupil size is. So if you rotate your rhexis with the macro, you can use a micro forceps also, and just an iris beyond the visibility of your pupil size, you can have a good cyst. So once it is done, the rest of the surgery is very easy. And most of the cases at the end of surgery, we are giving PST.
Yeah. And I agree with all the points, but I still feel that plaque or whatever was there has
in
to be
this particular case, let me say, it's a little hurried. So see, putting lens blindly in such cases is also a little difficult, because once you put lens, you may have a lot of lens matter behind the lens also. So try to address all the lens matter as possible to have the least post-operative inflammation. As you can have the intense post-operative in such cases.
Even you can take a help of immunologists, particularly in these cases. Apart from the routine investigations that you do at your end, take a help of immunologists, because many more times you find that whatever is being, escaped from your end, the immunologist can find it out as a systemic disorder in a person, and that will be a nice thing to take care of the post-operative inflammation or even the pre-operative area where you can
you might need immunosuppression also for these patients for a longer time. All the points very well brought out, Dr. R.P. Singh. Thank you so much. I think we'll go on to our next speaker, and I would invite Dr. O.P. Agarwal, who's a cataract, glaucoma, and a refractive surgeon and the medical director of Rohit Eye Hospital and Child Care Center, Indore. Dr.
One question, please. One question.
Yes.
If you would have put the lens in the bag, what are the chances of the phimosis, capsular bag phimosis later on?
No, you could aim for a larger rhexis, as Dr. R.P. Singh was saying. Go behind the iris and do it, and make it significantly large, not too large, but let it not be too small, because phimosis is a challenge in this.
Yes.
Very valid point. Thank you, Dr.